interactive, and of course I'm going to share with you kind of the work, particularly that we started, in the NHS in England around patient experience, and some fantastic examples of what's happening here in Canada and some examples of what's happening elsewhere. So, we're going to base it primarily on the stuff we've been doing in England, but absolutely share with you the broader set of examples so that you can learn case studies. And, hopefully what we're going to be able to do is convince you that this is a methodology, this is an approach, this is a set of tools that you can embed into all of your improvement work, and it's going to make a difference. And often in England, when we talk about working closer with patients, some sceptical people, so I know we have none of those people in the room today, but some sceptical people have said, yeah, but Lynn, that's a bit pink and fluffy, isn't it? It's not really going to make a difference. But hopefully today we will be able to demonstrate and share with you how this is not pink and fluffy. This actually really helps to deliver big impact for patients, for staff, for organisations and for health systems. It really makes a difference all the way through. So we're going to take you through the experience-based design approach. We're going to share some tools with you. We're going to get you to work on some tools as well so that you can have that in your tool set. And what we want you to do at the end of the session is recognise the importance of this as a way of working for the future in anything that you're doing, both within health and externally, and if you move anywhere else. Understand how you can actually use it, how you can practically apply it in your own setting, and use the techniques to take you forward. I'm going to hand over to Paula now, and I'll be tweeting, and I'll speak to you all later.
Thanks, Lynn. So it really is a privilege for me to be here today. There are a lot of friendly faces in the room, and so even though I don't live in the Southwest, sometimes I kind of feel like it's home. And it's also a huge privilege for me to be presenting with Lynn. As Lynn said, I've known her for years. I've always had a huge amount of respect and admiration for her, and so I feel absolutely privileged to be doing this with her. So we wanted to, is there a or we're just using If I stand here, I'm absolutely blocking you, right? It's okay? All right. So what I wanted to start with this morning is to share with you a story from a woman by the name of Lynne Maher. She's one of 15 patient and family experience advisors with Kingston General Hospital. I first heard Angela when I was at the LHIN publishing session this year. I know that I won't be able to tell the story as impactfully as if Angela were here in front of you this morning, but she has consented to let me share this with you because I found it particularly impactful. Angela's not a healthcare professional, but she has spent time in hospitals, supporting and caring for a number of people who she loves. These are Angela's words. My friend of 24 years, Bonnie, was diagnosed with breast cancer in the summer of 2010. For a year and a half, I was with Bonnie at many of her appointments. I was with her when she went to her GP, her surgeon, her oncologists, radiologists, pharmacist, social worker, psychologist, community care worker, eye doctor, palliative care team, and her hospice worker. I listened, monitored, recorded, tracked, supported, communicated, and advocated on her and her family's behalf. Bonnie and I started out incredibly threatened, stressed, intimidated, and terribly overwhelmed. We were lost in a labyrinth, figuratively and literally. We both had to learn to navigate our way through what seemed a foreign land, learn to speak a language that varied from region to region, and identify the roles of many inhabitants who were strangers to us. The longer we were there, the more I started to question why. Why didn't anyone contact the community care team to make sure Bonnie got her injection 24 hours after chemo? Why don't the doctors in Kingston know the results of the tests ordered by her doctors in Toronto? Why didn't someone tell us that her Cadillac hospital bed could be put upright in a standing position to make Bonnie feel more comfortable? Why is a cancer patient nearing the end of her life left to sit in a waiting room for longer than 3 hours with more than 100 other people? And I ask myself, who? Who's in charge? Who's the point person? Who do we call? Who is there to answer our questions? And how? How is anyone expected to do all this alone? How can someone so vulnerable, so frightened, be expected to keep track of all this chaos? And the more we question the system, the less confidence we had in the system. There had to be a better way. And then Angela moved seamlessly into her reasons for joining Kingston General Hospital as a patient advisor. She said, I'm now able to share my perspectives with a group of like-minded people who are honest, passionate, and sincere in their desire to make things better. We are not there to complain, but to share our concerns and make a positive difference. I have found a way to use my experience to help make the system a little less frightening, a little less overwhelming for others, to truly design patient and family-centered care. I know the change is slow, and it's not easy, but I feel hopeful. I feel heard, motivated, and excited. I feel empowered. I've become an active advocate for change instead of a passive, disillusioned healthcare critic sitting on the sidelines. In our fast-paced world, it's easy to forget that each electronic patient number and 3D image represents a real human being. The reason I shared that with you this morning is that when I heard it, as I said, I found it very compelling. But I know, and I know that you know because you're in this room today, that if only we ask, there are many, many people like Angela who are sitting on the sidelines waiting to help us to improve our healthcare system. They only need to be asked and invited. And so with that introduction, we are really privileged today to have with us someone who I've had the privilege of knowing for several years now, Jennifer Cassaverly, who I'm sure you all know, or most of you know, who's with the South West Community Care Access Center. And Kelly is here not only, not Kelly, Jennifer is here not only as a participant in the workshop because she is passionate about improving the healthcare system, but Jennifer's had the experience of being a family caregiver, supporting her husband who's dying of pancreatic cancer over the course of 14 months. Jennifer has written a book about it because she saw the system through an entirely different lens. And the book called Just Stay is very profound. I couldn't put it down, as I know many others couldn't. And Jennifer has agreed to share with us this morning a little bit about her story and her passion, and then I know that at various points throughout the day, she's going to feel comfortable just interjecting where she feels it's appropriate that she can actually share and help all of us to benefit from the extraordinary experience that she's had. So Jennifer.
I feel really inadequate to be in front of this room because Lynne and Paula are very famous. Thank you very much. So in August 2009, my background is that I'm an improvement advisor. I went through work with Paula and team back in 2007 with the Flow Collaborative and see a few of my colleagues from there at that time. And so I was working as an improvement advisor within the Southwest CCAC, working on patient flow initiatives when my husband Rob was diagnosed with pancreatic cancer in October 2009. By the time he was diagnosed, it was metastatic, had 13 beds in his liver, as well as a alcohol-sized tumor in his pancreas. And we were given a few weeks to maybe a few months. So in August, we were told maybe he'd make it to Christmas, maybe not. On the day that he was diagnosed, I called up the CCAC and quit my job and said, I really hope I might have a job to walk back to, but I don't know. But my priority right now is Rob. And I became his primary caregiver. We focused on his quality of life. We knew the diagnosis was terminal, and we were very quickly put in the position of being patient and caregiver instead of being I was a physiotherapist in a stroke program, and I was an improvement advisor at the CCAC. And that's a really different side of the fence to sit on. And we were quickly connected with an unbelievable care team. And because I'm someone with the CCAC, I had a bad email habit and a BlackBerry that I was very privileged to keep. And so over the course of 14 months, I had a lot of email connection with my care team, most predominantly a nurse practitioner who worked with me and a spiritual care provider. And those were the two people who were just so important to me and to Rob to get through that year. Rob died at home after 14 months. He had an incredible 14 months. He was very well managed. He never experienced hospitalization. He had excellent symptom pain control. And surprised everyone by living 14 months with metastatic pancreatic cancer. It's unheard of. And over the course of that year, the circle of people that supported us grew and grew and grew. We had friends and family and coworkers who support us. At the end of it all, about a month after he died, both the nurse practitioner and the spiritual care provider that I had worked with so closely and had so much communication with returned all of their emails that I had ever sent back and forth back to me. And those were some hard files to open on the computer, you can imagine, because they started in about September. Anyway, I did open them. And what I read was an incredible story. And it struck me that I couldn't just walk back to my job without somehow sharing this story with others, because I felt that it was so important. So I took those emails, and that formed the skeleton and the basis of my book. And I guess Paula has asked me to comment on how my experience has altered my improvement work and given me a perspective, and it's completely altered it. I did graphs, and I monitored ALCs, and I monitored all sorts of impacts that we were having on a healthcare system before my husband got sick. But when I came back, I was asked to do very similar work, and it just has taken on a completely different role for me. And a lot of the comments, Paul, that you just shared from other person resonate with me. I look at every dot on a graph now differently. I happen to have written down my story in a book, but everybody has a story like this, and everybody has an equally poignant and impactful and important story, every one of the dots. And so I find myself now that when we're making decisions about how we should restructure the healthcare system and how we should move dots on graphs, I find that I'm thinking a lot more about the people that are attached to the graphs, attached to the dots, and I find myself much more interested in the impact that we've had on the patients, on the actual patient stories, and I've really tried to bring that to the improvement work. I'm so looking forward to the next 2 days, because I think it will help me further. But I know that for myself, when I came back and was asked to start again as an improvement advisor, I just felt like there was something missing. I thought, I can't just go back to the way I was. So I think this is probably what's missing.
Thank you, Jennifer, and please feel comfortable as we go through the day. If you feel that there's anything that you'd like to interject, we will all benefit from your experience.
So what we're going to do between now and our coffee break, what we're doing is we're setting the context. And then right after our coffee break, we're going to dive into the first major piece of the actual methodology of experience-based design. So what I thought we should do at the outset, particularly since this obviously sponsored by the LHIN, but let's look at the alignment between experience-based design and some of our provincial priorities and some of the legislation and documentation that's come out over the past few years. We are in a good place, and everyone says to me, you've got such a great niche because quality is everywhere these days. And certainly all of you in the room will be familiar with the Excellent Care for All Act that was tabled in June of 2010. And in addition to requiring organizations, and I know it's just hospitals now, but we know that any day now it's going to be rolled out to other sectors. In addition to patient and caregiver surveys, there's also a requirement that organizations have a patient declaration of values, and that either through the creation of them or the updating them, there's also a requirement to consult with the public. So some notion of patient-centeredness, but certainly not where we believe we all need to go. Then Deb Matthews, in her action plan in February of 2012, just a couple of months before the Drummond report was tabled, there was, her action plan articulates that the plan is obsessively patient-centered and indicates that the priorities that are reflected in the plan are those that the government knows that the public in Ontario expects of our healthcare system. And then towards the end of it, she talks about the fact that in order to have right care, right place, right time, all partners, although she doesn't articulate patients as part of that partnership, must join together in order to get us to achieve the goals that are articulated in the action plan. And then finally, just this past November, there was some documentation put out about health links. Can I just have a show of hands of how many in the room know what health links is? So, what a great job you do getting information and communication out. So I don't need to describe what health links are, but in that documentation, it does state that it requires patients and providers to work more closely than ever before, and that patients need to be a part of the transformation. And so I thought, you know, we're seeing an evolution, and we're seeing words about patient-centered care and truly engaging with patients evolving as we see different documents evolve out of government. But what I would suggest to you is that in the fine print where we see who the stakeholders need to be in each of these health links, again, we still don't see patients identified as one of the key groups within the network. And so I think we all, as champions for this kind of work, actually need to make that so. And in fact, I know that there are a couple of tables here for today from Health Quality Ontario. And the way that that came to be actually is that when I saw some of the documentation for Best Path, and Kelly and I were talking about doing this within the South West LHIN, we were actually thinking about 2 workshops at that point, because I went to the folks from HQO and said, this information, and they're now aligning Best Path with Health Links, this speaks to experience-based design, and this speaks to engaging with patients as part of the improvement process, and we ought to bring experience-based design to it. And so through a number of conversations, the South West LHIN was gracious in inviting the HQO team of coaches here. And so the reason that I raise that is I know that all of you from the South West LHIN are here to work on initiatives that are spread across the LHIN for a variety of priorities that link to provincial priorities. In addition to that, in your work, if any of you are engaged with work that links to health links, I urge you to use this approach because it works for it. It is absolutely needs to be a part of it. But I would say in Ontario that we aren't quite where the NHS is, and the NHS would say that they aren't where they want to be yet. However, this statement was actually put out by the NHS government a number of years ago. And what actually happened, and if you look at it, you can see that it goes, I think, a little further than what we've seen thus far from Ontario, where the government set itself out to have a patient-led NHS and acknowledged publicly that it was at that time still far too frustrating to be a patient in their healthcare system. And they have done a huge amount over the last number of years, including experience-based design. And Lynne actually just told me the story that this was put out there as a policy statement, and then they actually didn't have any way to act on it, and they came to the Institute and said, Lynne, make it right, and fill the gap. And that was actually part of the seed of experience-based design. So, and in Ontario, we always say, we won't wait for the government, we're going to get out in front as leaders, and we're just going to do what we know is right. For any of you who have seen comparisons of Canada against the developed countries through Commonwealth Fund OECD comparisons, you'll know that for any number of quality indicators, Canada doesn't usually stack up all that well. Usually against 6 or 7 countries, we usually come in 6th or 7th, with only the US lagging behind us. In this particular comparison, this is through a public lens, and this speaks to the extent to which the public believes there are fundamental changes required in our healthcare system. And the two that are circled are Canada on the left and the UK on the right, and you can see on this row in the middle that there are far higher number of our public who believe that there are fundamental changes required of our healthcare system than is the case in the UK. And I don't know if you can see the detail there, but New Zealand is a country that we're just about the same as in terms of this particular survey. And in fact, the US does better than us on this. So we have a lot of room for improvement, and that's what this is all about, is doing the right thing, understanding our patient experience, and improving care to meet those expectations. And so, you know, I was going to do that. So we have evolved. We are in a better place today than we were several years ago. And that's the case in terms of thinking about patient experience. It's the case in thinking about where we are in developing improvement capability. We have, I think, gone pretty much from that far left column, which is doing things to patients. It's the situation where we have the locus of control. We talk, we expect patients to listen, and it's very much a unilateral conversation and relationship. To moving to in the middle, and I think many of us are still somewhere stuck in the middle, which is doing for patients. So we do invite patient and family input. We have more transparency of data now so that the public can understand some of what we are doing through measurement. But it's still very much a benevolent relationship. We aren't quite there yet, walking together with patients in a true partnership where we truly understand what their views and perspectives are, how they feel, where we really understand their emotions, and then we truly partner with them to work with us in a partnership to improve care. And that's where we need to get, and that is what's reflected in the right column in terms of co-design. And so this cartoon, which I'll just let you read for a second, really reflects that far left column, and it's what we need to move away from. So let's talk for a minute about where experience-based design comes from. It actually started, as I indicated, that policy and people coming to the NHS Institute for Innovation and Improvement and asking them to fill the gap. But there were a couple of individuals then who Lynne actually commissioned, or the Institute commissioned, to do some groundbreaking work and some research, I guess you could say. Names are Paul Bate and Glenn Robert. And they wrote this book, which I have a copy of here if anyone is interested in glancing through it today. And it really sets the foundation for the experience-based design approach. What they did was they looked at industries that were innovative, and they were looking for attributes that make those industries successful. And what they found was those successful industries were utilizing design methodology. A methodology where you use discovery interviews or in-depth interviews and actually do a lot of observation and watching and seeing, and then understanding what customers really wanted out of a product, and then in many cases joining in with those customers customers to help to redesign product. And so the Institute said, hey, maybe we can translate this to healthcare. And so a lot of the work that underlies experience-based design, and in fact a lot of the way that the Institute operated as an organization, was to utilize design methodology, in-depth interview, observation, and then joining in with either patients in experience-based design kind of work, but the Institute's also put out a lot of product. And in developing that product, they would actually co-design with the field. So it's just a philosophy that's taken them through all of their work and that absolutely naturally extends out to experience-based design. There has been a fair amount of research since that time, and then there's an evolving evidence base. And there are also a couple of practical guides that have been put out by the Institute. And again, I've got this one up here. We have a box of them that have been provided to the LHIN, and so each of your teams will go back with at least a few copies of this book. It's a very practical guide. You'll see when you've been through the workshop that it steps you through all of the steps, and then there are a few really nice, the latter half of the book includes a number of tools that are very useful for going deeper on each of the 4 major steps within the methodology. So speaking of evidence, these are some of the very early studies, and towards I think it's the very last slide, we have some websites where there is some other evidence if you're interested in looking for other evidence. We also have a handout if you're interested in further evidence that we can send you after the workshop that lists a variety of references, and interestingly, a number of them have actually come out over the last few years. These are some of the more recent ones. The first one highlighting when you truly try to design clinical processes with the patient in mind, there is evidence that clinical outcomes are indeed improved. Similarly, in that second one of the things that we often hear from patients that we fall down on and that really requires improvement is communication. What a surprise. We all know it as providers. And an indication that if we really work on improving the effectiveness of that relationship between patients and providers, we can significantly improve outcomes. And in this particular study, it was adherence to medication management. And then again, although we can do something to try to minimize the amount of fear and anxiety that patients experience through the processes that we put them through, nonetheless, providing emotional and psychological support can do a lot to help to allay that anxiety and fear. And what's demonstrated in this third study is that by so doing, there's a promotion of healing. So, as I said, an evolving evidence base, but as Lynn said, this isn't just pink and fluffy. There is an evolving evidence base if you feel through your work, A, you're interested, or B, you need that evidence base to share with others, to champion it and influence. There is an evolving evidence in Ontario as well, and for any of you who are familiar with the Change Foundation work, and if you aren't and you're interested in this, I would urge you to go to their site. Their whole strategy last year and for the next couple of years is focused on patient experience and particularly trying to improve that experience across the transitions of care. They have sponsored a number of initiatives. One of them was holding forums across the province over the past summer. And what they did was they held focus groups. And in addition to the focus groups, during the course of the day, asking a whole range of open-ended questions, they used those multi-voting devices, and they had 10 closed-ended questions on a Likert scale. And these are just a sampling of those questions. And at very high level, what you can see, if you look at the top 2 and the bottom one, those are the 3 where there's the most opportunity for improvement. And they'll kind of validate what you know as providers, that we don't do a very good job of helping people to navigate through the healthcare system. The perception of people we care for is that we don't work very well together as a team. And finally, at the bottom, if only they knew what the next steps were in their care trajectory, it would allay a lot of anxiety. So those were the 3 areas where we really need improvement. The middle one's not as much, and again, this reflects that individual provider-patient relationship that once someone gets in front of a provider, the relationship is usually viewed very positively. And so in the middle, what we've got is the trust that patients have with individual providers. The fact that, and there are areas, obviously there's room for improvement in all of these, but healthcare workers listening and understanding patient needs, and then in the final one there, involving them in care and in decision making. So this is all being written up in a report and a lot more detail called Loud and Clear. And as I said, it is on the Change Foundation's website. And I have no financial link to the Change Foundation. I just think that they're doing some very good work. Many of us are sometimes afraid to open the door and truly engage with patients because we're afraid of this. And I'll just move to the side so you can read it. We often fear that patients want a whole lot of things that in actual fact, when we do open that door, when we do invite them in, we find that it's actually not true. And again, this comes from the Change Foundation's work, and they've articulated the fact that patients don't want the moon. In fact, they don't necessarily even want more. They just want something different. They want us to, when they've themed everything, they want us to connect better with one another. They want us to communicate amongst ourselves and with them better. And they want us to include them in decision making and in their care. All really reasonable requests. And just a few quotes from them. If someone had just sat down with us to explain what was next in our care, it would have made a huge difference. A caregiver saying, I've never been asked, what's convenient for you, or how would this work in your family? Instead, it's, this is what we're going to do for you, reflective of that middle column, right? There's just no collaboration. And then the final one, where some astute patient noted that his family physician had an EMR, and yet it didn't talk to anybody else, and so he wondered what the use of it was, because the hospital couldn't get the information, the specialist couldn't get the information, and thus the patient kept repeating himself, and stuff got lost through the cracks. So we've taken the first good step, now we just need to get everyone linked together. And this patients don't wanting the moon reminds me of a story that I once heard at a conference. It was the Studer group, focused on patient experience and improvement. And what they said was they were urging everyone in the room to, this was up to a hospital room, before you leave the patient's room, please just stop and say, is there anything else I can help you with? Providers are so afraid to ask that question. And why? Because everyone's run off their feet and they're afraid of what patients might ask them to do and that they're not going to have time to follow through. So don't ask a question, right, if you can't follow through on it. He said, I promise you, no one's going to ask you for a colonoscopy. But the only thing they're going to ask you to do is to maybe move the bedside table a little closer, to draw the curtain. Something that will take you a fraction of a minute and will go such a long way in terms of improving that person's day. So they don't want the moon. So the Institute did some work on what really, really matters to patients. And they did it through a series of in-depth interviews as well as analyzing some information on an online website. And then they themed them through qualitative analysis and divided them between these two categories of sort of the functional and more technical aspects of care and the relational, more emotional aspects of care. So I know you can't see the individual rows here, but what you can see is the large number of check marks beside those emotional, relational aspects, the things that really matter to patients. And yet, often through our improvement work, and I'm as guilty as anyone, what do we focus on? We often focus on this side, and that's not what really matters to patients. And then just so that you can actually see what's in those rows, these are some of the things that patients said really matter to them. Feeling informed and being given options, listening and spending time with them, not feeling like a number, all of these sorts of things. And efficiency is important to them, but it's not at the top of the list. So we need to reframe our whole approach and make this a much bigger, a much bigger part of, or a complementary part of our improvement practices. I don't know what you're doing with the Southwest.
We're doing a variation on it because we actually think some of these questions are still a bit blunt in the wording. So we pulled it out and are doing the same thing with all of our providers and our staff. They're just a slightly different wording.
Okay. So this is something that's starting, because I know Toronto Central's doing it. I know that there's another association doing it, and I was just asking Sandra whether you're doing it in the Southwest. What she was saying, if you couldn't hear her, was they still think some of the wording around these questions is a little bit doing poor, and they're trying to modify it to improve it even further. But what they're trying to do to try and improve some of their experience survey results is something similar to what I was just talking about with the Scooters group, is going in and saying at each visit, what is the most important thing that I can do to help you today? And one of the things that was shared with me was that it's very difficult to get providers off that reason that they went into the home in the first place. And they've given them permission to do this. And obviously if there's something, that is technical and really time sensitive, they need to do that. But giving staff permission to be flexible, and they're having a lot of difficulty, at least in this one CC, doing it. And then halfway through, is there anything else that I can do to help you? I have time. And just uttering that I have time goes a long way. And then finally asking if there's anything that they can share back with the office or the care team. And I'd be interested, Sandra, later to hear about how you're rewording those questions to make them even better.
Sorry.
Yeah.
The first question, would patients ever take that as, I only want to help you with one of the most important things today? Because I'm just wondering, if I said that to a patient, would they say, or would they think, you only want, if I go to some physicians now say, you have one topic today, and I got 20 minutes, and that's all I'm covering. I've heard that a lot from patients who go into a physician's office like that. So I'm wondering if they take it that way.
Well, and I guess you don't have to frame it exactly like this, and it depends on someone's frame of reference, how they interpret what you're saying, right? If people have had that experience in a doctor's office, they may well interpret it in this way, but I guess you could reframe it and suggest what you're there for, but say, well, I'm here, what is the most important thing for you, or, word it however you feel comfortable. I think it's the core of what is intended here that's important. Sandra, do you want
That
to
is one of our changes, actually. So we rephrase this around what is important for us to work on together today as partners.
Okay.
That's how we phrase it.
And of course, even if someone interprets something that you say in a way that you didn't intend, you can always follow up and reframe it with them. So, I've talked enough. Now it's time to get you to talk a bit amongst yourselves. What we're interested in understanding before we move into the second half of the morning is to get you to share amongst yourselves, and then we'll get you to share with everyone. The methods that you currently use, now you're sitting with your project team, so this can be as part of your project team, the methods that you use, and or your individual organizations as well, that you use to capture patient views and experience. And then once you've done that, talk a little bit about, once you've got that data collected, how do you actually use it? So take 10 minutes at your tables and discuss it, and then we'll do some sharing. We've got a couple of local stories and then a couple of stories from the UK to demonstrate to you how impactful this experience-based design approach can be in terms of the way that an improvement team heads down a path versus where they might have headed without the experience-based design approach. So I spent a bit of time with some teams. We're early days in Ontario, and there are some groups beginning to experiment with experience-based design. One of them is Cancer Care Ontario. They participated in a session with a colleague of Lynn's and someone else from the King's Fund in the spring, sponsored by the Change Foundation. And they were really there because there's a whole group up in Northumberland who are being sponsored by the Change Foundation in an initiative that focuses on the patient experience. So they took the approach, and in the London Regional Cancer Centre, they had an issue a few years back that they were dealing with within the radiation therapy treatment program. And they were getting a lot of patient complaints around canceling appointments. And what they found was that for every appointment that they canceled, it had an impact on at least 2 other people, if not more. And they tried to grapple with it, and it was really challenging, and they ended up just putting it on the back burner. It was hard, as all improvement work is. And then what happened was, after the workshop, they needed to identify an initiative that they were going to sort of experiment with action-based learning and start testing out the experience-based design approach. So they resurrected this issue and thought, we're going to tackle this with experience-based design. So patients have up to apparently about 40 radiation therapy treatments in a fairly consolidated period of time. And as I said, there were all these cancellations. And so what they did was they did their mapping, and Lynne's going to walk through this in a fair amount of detail with you later on. They mapped through doing in-depth interviews and then some of the emotions, and that's what this slide is about. But what they found when they talked to patients was there were a few themes, one of them being communication. And there were 3 things that patients told them that they wanted. One was they wanted to understand the booking system a lot better, because even if they were going to have their appointments changed, they wanted to understand what it was all about and how the booking system worked. Oftentimes, just sharing information goes a long way to helping someone out. Secondly, they wanted consistent information among providers, both within departments and across departments. And finally, they wanted some input, some final say into their own personal schedule for radiation therapy appointments. Again, not unreasonable requests. And what they also found through the experience-based design process, that outside of those issues that patients identified, they were very complimentary. They were very complimentary about the interaction at the individual appointments. They were very complimentary about the amount of time they were in the cancer center. They found it to be very efficient. What they told me was that, unlike the past, hearing how emotionally impactful it was not to understand this booking system and not to have any input themselves on patients has assured them all on the team that there is no way that they would put this on the back burner again. They are going to persevere. And even though from the sound of it, they don't sound like major requests that the patients have, they are challenging from a process improvement perspective to resolve. But again, because they joined with patients on the improvement team, they are going to persevere. There is absolutely no way that they are putting this on the back burner. They are going to resolve this and move on and have it fixed. And they would not have done that without the experience-based design approach. So that's one story, and this is, again, just a couple of quotes, one from a patient and one from a staff member, revealing just how much the experience-based design approach brought to them as a methodology. Another story that comes to us from Paula and Norview Kids Rehab, and they actually attended a workshop that Lynne did with CHQI 3 years ago and had been experimenting with experience-based design. And they told me a story about a team that they put together, and they had 2 parents as part of the committee. And what they were doing was they were taking their comprehensive assessment from their outpatient clinic, and they were translating it into an electronic health record. And the providers on the team figured they were going to sit down and just tweak around the margins, and then the real job was to translate it into an electronic health record. And the parents sitting on the committee just said, whoa, that is a non-starter. We don't like the current assessment. It's 12 pages. That's a non-starter for us. We need a 1 to 2 page assessment. And it's not helpful for us to get it 3 to 6 months after the fact. We need it immediately after the clinic or shortly thereafter, because we need to share it with their children's schools and with their primary care physicians. And so there was a bit of negotiation back and forth, because The feeling of providers was everything in that 12-page assessment they needed to hang on to. And why did they need to hang on to that? Because the colleges required it of them, their professional colleges. And we all know from doing some of this improvement work over the years that some of that's truth and some of it's myth. So what they actually did was they called in each of the individual colleges and sat down with them and said, what do you actually require of us? So long story short, having these parents on the committee totally changed the outcome. They changed the content, they changed the process for actually developing the assessment and doing it. It became point of care. It wasn't 1 to 2 pages, but it was a significantly shortened assessment. And because it was done at point of care, parents got the assessment form either at the end of the comprehensive assessment or at the next visit. They said the impact was overwhelming on the professionals, on the team, and also on the ultimate outcome. So examples of impacts in terms of indicators, quality and efficiency. This is a story from the UK, and this is a sort of an example of how profound stories are, because I remember this story from 3 years ago when I told it. I didn't even have to look at anything else. This is an example from a hospital in the UK, and it's a story about a patient who sustained a stroke and was totally paralyzed on one side. This patient was due to go home 2 or 3 days later, and the staff noticed that this particular patient was very anxious about discharge. And not only that, the patient also was becoming dehydrated. And so they sat down with the patient to try to understand what was going on. And what they learned was the patient was afraid to go to the toilet because the toilet roll holder was on the wrong side, and every time they reached for it, this poor lady felt like she was going to fall off the toilet and fracture her hip. And she was unbelievably anxious about going home and falling on the floor and being left there on her own. And so she had stopped drinking because she figured if she stopped drinking, she wouldn't have to go to the bathroom that much, and she would mitigate her risk of falling. So by having those conversations, the quick fix by the hospital was to put toilet roll holders on both sides of the toilet. Like, duh, how hard can that be, right? But we don't talk to patients and understand what their issues and their problems are. And sometimes, not always a quick fix, but oftentimes it really is. So
I'm just going to add to that, Paula, because on that ward, when we went back and looked at the data, the pure data, it was staring them in the face that they'd had more falls from people who'd got a deficit on the right-hand side than any other, and that's because they were having to reach over, and patients who've had a stroke often have imbalance, feel imbalanced. So the data was there that there was a problem. I think 98% of the falls in the toilet were people who got a right-hand deficit. But that data was not as impactful as the story in making change happen. And of course, when the toilet roll holders went on both sides, how many falls did they have? 0 for about 2 years.
one final story, and this one reflects how not only can we improve things through improve the quality, but also decrease costs, and that is often the case with improvement work. But this again is a story from the UK where there was a regional hospital, and because we always hear care is better when it's closer to home, the hospital believed that for this group of patients who had multiple sclerosis, what they would do is rather than having them all have to come to the regional center for their follow-up appointments, they would decentralize the clinics and put them out in some of these suburban and rural areas in order to make it easier. Then they actually went to start talking, and it was going to be at significant cost, equipment, clinics, etc. They went to talk to patients about what they were doing, and the patients said to them, actually, we like coming into the regional center. And they liked coming in for a few reasons. One was that they actually found it quite supportive, a support group to be with other patients and talk to them in the waiting room and whatnot. The other was that they got other things done, whether they were either testing things in the hospital or just coming into the city and being able to get things done.
And what they said to them was, if you've got some resources to put aside, what we'd rather have is, we'd rather have some support for vocational assessments, better wheelchairs. We'd actually like a virtual website, support website, so that we can link in with one another and form a virtual support group. So a variety of things that these providers weren't thinking about. And in the end, the outcome was clinic that the patients wanted to come to, a lower cost for the hospital, and a few tidbits that they were able to do for them to support them in things that they actually wanted. So I think we should take a break.
Yeah. As Paula said, we really are focusing on experience rather than attitudes or opinions. And that's the experience of the person who's going through that journey now. We do look at the experience of staff members, but we use the experience of the person. Oh, it's just nicked my notes. That's it. So we actually do use these tools and techniques for staff as well. As you know, their experience of providing care, as well as patients or residents or clients or customers or consumers' experience of receiving some care. But we're really focusing on that experience now. So there's a huge value of working with people who are patients in the system and have been patients in the system. But if they're not going through that experience now, they're not your number one client group for learning about how it is now. Because if they went through that experience 6 months ago, it might be quite different to how it is today. But what we've been able to do with the patients who we've been working with 6 months ago, some of them have then been the people who sit down and help people tell their stories and collect questionnaires. So they're really helpful people. But it's important around experience. And I just also want to say, on your slide set, you haven't got all the slides that we're showing. And particularly things like the cartoon ones, because if you saw them beforehand, they wouldn't be funny. But I'm very happy for you to have the slides afterwards if you want them. That's absolutely fine. So earlier on, Paula mentioned that a lot of what we were doing around experience-based design came from design methodology, and that was where it was started. When I, through the Institute, got asked to kind of find an answer to the challenge that even though we've got a political imperative and a policy that says, you must work closely with patients and they've got to be really involved in designing our health services, it wasn't happening. And when we started to ask people, why aren't you doing it? And they were saying, well, we're not sure what to do. And that's when we started to look at other industries to say, well, what other industries have an interaction with a customer group, a consumer group. And mostly it was the service industries, hotels, conference centres, retail outlets, airlines, people like that. And we went to visit quite a few to say, what do you do? How do you interact with your customers to make sure you're really working with them to give them the best experience? And we learned lots from that, but one of the things we learned was the majority of them either employed a person called a service designer or a person with skills of a service designer, or they bought those services in. Now, this was about 7 or 8 years ago, and it was the first time I'd really heard of the concept of a service designer. I mean, I knew there was designers, they make the chairs, they make the glasses and things, but I hadn't really thought about designing services. But it is a separate body of people who, there's those people who are fantastic, design the buildings, design the conference centres, design the planes, the chairs we sit on, everything around us. But there is this separate body of service designers, and what they look for is how people are experiencing the service and what will make that better. And industry outside health absolutely take this seriously, because if they can provide a fantastic experience for their clients, then their clients are more likely to come back or recommend them to other people. So for those organisations, it was really important. Anyway, when we learnt about these service designers, I then found some and said, what do you do? You know, how do you work? How do you interact with people? And most of our learning has been adapted from what the service design industry have been doing for years. One of the things that was really important and struck a chord with me was from a service design textbook. And they talk about looking at performance, and performance is really important. Well, we look at performance in healthcare as well. You know, how well does the process flow? What's the functionality of that flow? So we've been doing a lot of work in that. Engineering, they say, is important, and the analogy in health for me was safety. You know, how reliable, how safe was this process? We do a lot of that. Aesthetics of experience is the third thing in their book. I thought, okay, this is where we're not focusing. And the designers said to me that even though in this textbook the model is performance and engineering and aesthetics, actually they typically switch it. And they say if you get the aesthetics right, if you understand the process, the experience, not the process, from the consumer point of view, the patient point of view in our case, actually you get the other things right as well. And so they, typically designers would tend to look at the aesthetics of the experience. How does it feel? How is that experience? How is my experience going through that service? And then what comes out of that is things that are working really well and things that absolutely need some more work on them to make those processes and the experience function well. Now, the two researchers who worked with us, Paul Bates and Glenn Robert, were observing quite a lot of our work and observing us as we were looking at how people actually do service improvement. And Paul Bates came up with this, and he said, actually, what I'm seeing is healthcare staff either don't listen very much to patients, don't really take what they say into account, and they just go and make the improvements or redesign. Sometimes we listen to those patients or consumers, but then we as clinicians and managers interpret what they've said, and we go off and then redesign it based on our interpretation. Now, that's better than number one, but actually it's flawed. Because often we'll put our own spin on what we've heard, and then it's not quite right. Where we needed to get to was not only listen and understand the experience that patients are having, but then work with them to implement any improvements. Because otherwise what we tend to find out is we as clinicians and managers will tweak it to how we want it. And we need to move that. We need to move towards three. And I think that's one of the purposes of experience-based design. Now we talk about experience-based design as a method, a set of tools, an approach to use. And you can use it in many different ways. And typically we would use it within improvement projects, for example, at any stage. People are now using experience-based design methods just to check how things are in their ward or department or community. So you can use it as a day-to-day check. You can use it in an area where you think you've got some challenges, where perhaps that process isn't performing as well as expected under whatever your organisation's performance metrics are. You can use it if you get a lot of complaints in a particular area. So there's multiple ways that we use it. Now, certainly anybody who's got anything to do with the Institute, including all of our staff, we would never start a piece of work without using this approach. The first thing we do is talk to the users. If somebody says there's a problem, we say, oh right, and then we go and talk to the people who are experiencing that, and actually we get a completely different view of what the problem is. often there's something underlying that is causing the problem. And if we hadn't talked to the people to understand that better, and that does include staff, we would be improving the wrong thing often. So we always do this and we always teach it. And this approach, I'm going to talk a little bit about this towards the end of the day, but this type of approach has been adapted in all of our recent projects, including work on releasing time to care, which some of you might know about. There are some releasing time to care sites here in Canada. And it has also led to other things being developed, and I'll mention those later on. So there's many ways that you can use this approach. And the core principles of this is that it's a partnership. And this is quite difficult often. We found it quite difficult at times in England to have healthcare professionals working in a true partnerships with patients and family members. The emphasis is on experience again. We really spend a lot of time understanding through narrative and observation and some of the tools we're going to go through about what the experience is. Then we want to go away and co-design services. So this is number 3 on Paul Bates' list, not we'll listen and then we'll go off and design. And of course then we want to evaluate or work through whatever measurement hierarchy we have to understand what impact there has been. Now, I've put this slide in just because we did have some difficulties at first when we started using this approach where sites were saying that their ethics committees, their local ethics committees were saying, you can't do this work without getting national ethics committee approval. And we went to see in England our National Ethics Committee, and they said, if the work interviewing patients, and I soften that, it's having conversations with patients actually, is for the purpose of service improvement rather than the purpose of research, our ethics committee in England say you do not have to have ethics committee approval from a national level. And for our teams in England, we've got a copy of the letter that the National Ethics Committee sent to us so they can share it with their local ethics committees. Now, some local ethics committees have still said we want you to present something so we can give you local approval, and that's fine. The one thing the National Ethics Committee said to us is even though you don't need formal ethics approval, actually you need to make sure you put in and talk about in any of the guidance you're giving to people that it must work towards good ethical standards. And that must include actually having somebody slightly outside of the project that will be known to the patient group that they can go and talk to if they're worried about anything. And it must include that any person, patient or staff member, at any time can withdraw without any question. And so we just created these bullet points to be helpful. Now, locally, people need to adapt those sorts of things, but it's just very important that, one of the things with patients, some patients are quite nervous about being involved because especially if they're still in treatment, because they say, if I don't say something complimentary, will my treatment be changed? And, they can be quite fearful, and equally for some staff, we're asking staff to share their experience of how they're giving care, and sometimes that's frustrating for them, and they can be quite nervous. So we agree to attribute everything, anonymously, unless people are very happy for their names to be used. So just be aware of that. I'm just sharing this as our experience, and we need to think about that for Canada. Do we have a question?
Lynne, could you talk a little bit about how you recruit the people that are participating
Yes.
in experience-based? Is that later in the
Yes.
Okay, fine.
But fantastic question, thank you. And I will come on to that, because it is really important. So we've been talking a lot about experience-based design. So what's this methodology? Very simple. I think some of the tools and techniques you're already using, you've already heard about, but we're just adapting them in a very specific way. In our experience-based design guide that you'll get for your teams later, you'll see this. And first of all, we capture the experience. We really capture what's happening using a number of different ways. Then we understand it. So what is that telling us? And we understand it together with the patients. And then we need to improve it. So again, we're working co-designing improvements with patients and family members, and we need to measure it. And of course, measurement often sits at the end, but it is one of those things you need to think about early on. But clearly we want to demonstrate the impact that this had. So I'm going to, before lunch, I'm going to go through the capture stage, and then, which is the biggest stage, it's got the biggest number of tools. After lunch, we're going to go through experience, and then Paula will talk about improve and measure sort of later on this afternoon, and then we'll talk a little bit about other sites and other things that it's found. So you're all good, ready to get on to capture? Is there any interaction in this room? Is that yes? Yes? Fantastic. Well, I would say, Rob's been tweeting. He's already sent a tweet, which has now been retweeted. A number of organisations have retweeted it actually, so Rob is now famous. So now we're on to engagement. So to answer your question, initial engagements of patients, consumers, clients, and family members, and staff. Staff are a little bit easier, especially if you're working in an improvement project, because they're already there. Staff are easier if you start to work in one area, because they're already there. But in terms of patients and clients, actually it's a messy area. And there isn't one size that fits all. You have to think about who the people are, what sort of service they go through. So for example, we've done quite a lot of work with people who have cancer. So of course they tend to be what we call in the system for quite a long time. We've also been doing some work with people flowing through EDs and outpatients and day surgery. So their experience of the service tends to be more quick, and the perception is they haven't got as much time to spend with us. So we think about the client group that we want to work with. We think about the time that they're going to be either with us in an organisation or in a community unit or anywhere like that, or care homes. We've been doing work in residential care homes. And think about their capacity to interact with us. And just lately we've been doing some work with people who've got early dementia. And of course they're entirely different to a teenager or to a working mother or to a mechanic, for example. So you've got to think about some of the people that you're working with. And one of the mechanisms we use is talk to the healthcare staff and say, that are working with you in a project or have identified something in the way that they want to work with you, and say, do you know anybody who might be a good kind of reporter of how it feels? Now, of course, there's going to be bias in that, because the healthcare professionals might talk to somebody who's lovely and who loves them, because, they're not saying nice things, which is fine, because you want to hear that. And we call those people, or designers talk to call those people extreme users. So there's an extreme user who is very, very positive, or very, very negative. There's also extreme users who actually never say anything at all. And you need to think about those people. A quick example of that is a data issue came up in a particular hospital, that there was a group of patients with a very, very high stillbirth rate during pregnancy, and it was a group of Indian women. And now, sadly, that stillbirth rate had been high for 3 years, and only now it was coming to pass to say, oh, we need to do something about that. And we agreed to work with this team and said, well, what have you done before? And they've written letters to the ladies, and of course got minimal response. And they did write letters in the relevant language, but it still didn't get any response. So we actually contacted a community worker who works in that community and said, do you know anything about this? Do you know anything about why people these women aren't accessing services, and how we can find out? And our breakthrough was through that community worker, who basically said, well, there aren't any female obstetricians, and these women cannot be examined by a man. You know, no letter's going to fix that. And so we then went to the community worker, set up a meeting with us, and we went and talked to some of the women, you know, through interpreters, and got their stories. And eventually, well, what happened quite quickly, not eventually, was a female locum, temporary locum until the full-time post got appointed, came in, and it changed. You know, slowly, we did some clinics, or the local did some clinics in the community centre to begin with, to build that relationship, build that trust. But then, you know, very quickly after that, these women were accessing services, they were getting the proper care, and the stillbirth went down. So, you know, I'm telling you that story to say you've got to think about the client group. Now, in some areas, say outpatients departments, there's people sitting there, and you know, you might just put a poster on the wall. We've done that, and use leaflets and said, you know, there might be somebody walking around, like I might be there, staff member might be there saying, oh, we're doing this, are you interested? Here's a leaflet, here's a number, here's my name, get back to me. You can do that on wards. It's much better if you can put a human face with this. Because again, if you think about how you experience somebody giving you a leaflet or somebody talking to you, you are more engaged when somebody's talking to you. We will sometimes we do write letters, sometimes we link into forums of people who are already in organisations saying, you know, can you come and work with us like this. Sometimes we will target where there's been people having a number of complaints, and say, we know you've had this complaint, we know it's gone through the official system, we're doing this particular piece of work, would you mind helping us a little bit more? You need to think about whether you bring people in or whether you have telephone interviews. Actually, quite lots of people like telephone interviews, especially if they've complained. You need to think about you know, the time it might take. Longer term, people with longer term conditions actually tend to give more time. Older people who have perhaps retired tend to be able to give more time for in-depth interviews, but not only those. You know, we'll often get quite a lot of time from people who you think haven't got a lot of time because they're so passionate about something. So there's no easy way, but we often use a multiple ways. We'll create literature, small leaflets, make sure there's, you know, if it's me, contact me, they'd have my picture there, so there's a face to the name and a number. We'll sit in areas and just say, look, we're doing this, would you mind being involved? Lots and lots of different ways. I'm just going to pause for a minute just to see, yeah.
I have a question. I guess depending on the size of your project,
Yeah.
how many people might you invite to be on the committee?
So first of all, I'm going to be rude, I would never call it a committee. And I say that because in England, and it might be really different here, if we say committee, the mindset is, oh, there's a token patient on this committee. And you know, there's a real value in patients being on committee. I'm absolutely with that. But what we're doing is working more in a bespoke way, and as we go on, you'll get that. But just to answer your question, again, it's really interesting. When we first started this work, I was really anxious because the designers who we were working with said, actually, you just need to start with a few patients. The researchers were saying, oh no, you need hundreds, and you've got to, you know, get every ethnic minority and everything. And so, in fact, we worked with the designers because we knew that the researchers were right. But we said, well, we've never tested this small scale and whoever, so we did. And initially we worked with about 10 patients, but quite deeply. Now, we've got some projects in New Zealand, and we've had some outstanding stories about radiotherapy mask that people have to put on, where they've been talking to 4 patients. And the narrative from 4 patients who've had to have that mask on has been enough to make people say, hold on, we cannot do this anymore in this way. So you can get some really good insights from small numbers. What we tend to do now, I've got a slide in a minute. Here we are. Is think about it as a T, and we think about breadth and depth. And so what I try to do is get a little bit of both. And if we're looking at depth, that tends to be things like conversations, interviews, tends to be filming that might take quite a long time. And then when we're talking about breadth, we can do more snap surveys. We use what we call the experience survey and things like that. So, and both of them, then when we map them, we can see how the insights collate. So actually, and I was really, really sceptical when the designer said to me, we'll just do 4 or 5. I was thinking, no way, this is not good enough. But I'm a complete believer now, because I've seen it over and over again. You just start with a few people. And even if you start with 4 or 5 people and start to get some stories, that gives you some insight into what's happening. And just going on to here, so the learning that you get from this about the experience of the service is quite valuable. And really we need to understand what's happening. We need to get the hindsight of how this service is, and then that will give us insights about what we need to do about that. And foresight is about then working with people to design what it should look like in the future, depending on what, building on from the insights that you've got from their experience. So I think this is quite a neat way of looking about it, but without a doubt that middle one, the insights that you get are tremendous. I mean, the story that Paula told to open the session, fantastic insight about what was kind of wrong with the service. And the other stories that she told about the multiple sclerosis, and we call the toilet roll holder story. That insight about that toilet roll holder was from 1 patient, and yet you could say that 4 patients in her, in the same sort of group as her with the deficit on the right hand side weren't having that, but it was 1 patient that gave the insight to make a significant change that would stop people falling and breaking their hips again. So does that make sense? Question?
I think I know the answer, but I'm thinking you're starting with a problem that has come out in some of your data. You're starting with evaluating a new approach, or it could be one first person, I guess. I'm just wondering what triggers.
That's a great question. And you're right, lots of things can trigger this. So it might be, there is a desire by the organisation to do an improvement project. It could be, there's a number of complaints here. It could be 1 incident that you're saying, this is strange. Or it could be that data has identified something that you're not quite sure. So in the example of the Indian ladies, the data was there, and that triggered a different way to be able to understand what the problem is. Jennifer, thank you.
I also wonder, I think that's where I always thought about experience design, is that you start with a problem. But I also think in healthcare, I think there's lots of times where we're very satisfied with mediocrity, and on occasion you see an experience or a story that that sometimes is stumble upon or see an experience or a story where something works out much, much better than you would think. And I wonder if that's another opportunity, because I think that on occasion we do come across these wonderful stories, and then it's a matter of digging through that experience and saying, what were the key ingredients to that wonderful story that made it work really well?
Yeah.
Because then we can strive to, go beyond mediocrity.
Absolutely, great, that's really good. It's, I think the ways to use this are boundless, and there's lots of different things that have happened. And one of the things, I think it was one of the sites in America. They were doing it. They were thinking about doing experience-based design, and it was in a consultation area, like an outpatients area. What do you call it? Office practice or something? Get the lingo wrong. And they weren't sure about where to start because they thought everything was good. And so one of the staff said, well, why don't we see if everything's good? And they said, instead of doing a satisfaction survey, let's put some, and they got some Perspex tubes, and they put them outside of the doctor's rooms, and they had some tennis balls. And the Perspex tubes were something like great, okay, not good, and awful. And when the patients came out, they were invited to get the tennis ball and put it in the Perspex tube that best reflects their experience of that visit. And it was slightly tongue-in-cheek at first, but the doctors went with it, which surprised me because they wouldn't have England. They have it hidden behind a table. So they went with it, and what they found was that the patients liked it, and because they were walking away, they felt brave enough to put it in the Perspex tube that really reflected their feelings. And they could also sign up to then be interviewed or have a deeper conversation. But what else happened was when the patients came out, the doctors stuck their heads out to see how they rated them, and they were looking at everybody else's as well. So it set up this competition, and what happened, the staff found without doing anything else, the ratings went up. Because if a doctor saw that somebody was putting awful, they would then try to be more helpful or help. And the ratings went up without doing anything else, just by showing. So, some of those who had put awful, the staff did say, absolutely you can choose, but if you want to tell us why it felt so awful to you, then, give us your story and we can do a little bit more. So there's a number, you can almost use it in any circumstance, I think. And in England, again, what's happening, there's some rounding where, on ward areas particularly, where, once a day or even once a week, a nurse will go and sit, or the ward manager will go and say to a patient, do you mind if I just come and chat to you about your experience on the ward? So they'll do it sort of kind of unprompted, but then they start to build a database over time of how that ward area is being experienced. So, you can use it proactively to identify issues. You can use it because there's a data tells you something's going on, or you can use it as part of an improvement project or just as ongoing. Okay. So in the first phase of capture experience, we want to really understand that from the people who are experiencing it. I'm mainly going to talk about patients here, but we equally work a lot with family members, and particularly clearly for children or people, well, in any case, we use family members a lot. We really try and understand family members if they're carers, or if they're looking after somebody or supporting people with long-term conditions in any way. But also we do it with staff. And so we use what we say at interviews, but I just want to make this clear, this is not a professional research-based interview. It's a structured conversation, so we're not saying any of us are trained in interviewing techniques, but it's more of a structured conversation and listening. We use storyboards, still photography, film, and all sorts of other illustrations and diaries. And actually, diaries are better. Staff in England like diaries better than any of the other things. And we've been using it quite a lot on our releasing hunter care programs. They use quite a lot of diaries. And staff in care homes are using diaries. A question?
Who has the diary?
The
client or
the client.
staff?
The client. But also staff might want to keep a diary of their experience of providing that care, but it's the person who is sharing their experience has the diary. And sometimes it might be a family member who's got the diary. And also we use what we call observation. Now observation is a tool, again, when the service designers, now I'll tell you about the service designer, the first one we worked with, her name's Deborah. And she's a very young, enthusiastic service designer, and she only wanted to work in what we call the public sector, health, and areas like that. And so she came to work with us. She was an entrepreneur, she set up this business, came to work with us. I think we were her first big client group. But I'd seen some of our other bits of work before. And our first work was in a hospital. And I said to Deborah, we've got to go to the board, to talk to the board in this hospital, because it was an early test site. So you need to come with me. And we're going on a Tuesday afternoon. She said, right. And it was a very wet and rainy Tuesday afternoon. And I was waiting for her in the reception, going to this very important board meeting. Deborah, who was 24 at the time, turned up. She'd had a really good weekend. She had her hair coloured pink. And because it was raining, she'd got pink Wellingtons on to go with her hair. And she'd got a skirt on that I wouldn't describe as a skirt, I'd describe it as a belt. And she's got about 17 necklaces and 3 scarves. And of course I looked at her like, what are you doing? I was thinking, where can we go to buy Deborah more clothes? I'm not walking. But we were in 10 minutes and she turned up, just 10 minutes later and I'm dead in the water here, The board will take one look at Deborah. And Deborah knows I tell this story. She still dresses like that. And so we had to go in, and the chief executive, who I know really well, his name's Stephen, when I walked in with Deborah, he mouthed a phrase to me that I'm not going to mouth. It had a very rude word in it, and I just went, oh no, here's Deborah, she's a designer, and you can tell that because she dresses differently from the rest of it. But actually, the interaction, because Deborah absolutely was passionate about what she does and had got really good experience, we were able to do this. But anyway, so Deborah, the girl with the belt and hair, taught me about observation. And when she first said, we're going to do observation, I said, look, Deborah, I'm a critical care nurse by profession. I said, I'm a trained observer, And she said, no, you're not. You don't do it properly. I'm like, okay. And, what she described was clinicians typically, I'm simplifying it, but, we're observing for a specific thing that we can link to some sort of diagnosis. And we're very purposefully looking at, a rise in, temperature and blood pressure and things like that. And that's all we're looking for. Actually, we don't observe very much else. And what Deborah says is you need to observe in different ways. And you just need to observe. And of course, I said, well, what am I looking for? She said, you'll know when it happens. And that's quite difficult for clinicians to do. But actually, it's true. And by just sitting and observing, you really, really see things that